Got it. It's working. All right, you're good.
This was a case sent to us here. Let me start with the for CTEPH, and this is, I'm sure people have shown this. I just haven't seen one shown, but I'm sure, again, I'm not always here, where this was sent to us for CTEPH. You can see that the left pulmonary artery extending into all the left upper lobe and left lower lobe segments are filled with basically calcification extending all the way out distally. And you can see all this calcification and soft tissue around the left main pulmonary artery. The left superior pulmonary vein is obstructed. Here's the non-con, which nicely shows the same. So I think we told them that this was not CTEPH and not operable, but this is fibrosing mediastinitis, basically invading into the pulmonary artery and filling the pulmonary arteries. Have people shown cases like that here? I'm sure they have.
I remember cases of it of calcification in the SVC. I don't remember something like this.
Yeah, I've seen it in pulmonary veins. I've never seen it in a pulmonary artery. We were all like, that's pretty cool. But given how common Jeff, how often Jeff shows fibrosing mediastinitis case, I figured he must have shown a case. I've never seen one, but I thought that it was pretty cool how extensive it was.
Yeah.
Dave, you ever seen anything like that?
No, but I'm wondering if the vein was or arteries were compromised from the outside and then basically thrombosed and calcified, secondary to already being obstructed and not having any flow, rather than having the fibrotic process invade into the vessel itself. I mean, is that a possibility here, that it's?
I personally don't think so, because I think we've seen a lot of obstruction, proximal obstruction from long-standing for decades from CTEPH, and we've never seen anything like this calcify. So unless it's something unique to this process that allows for that to happen, we've seen a lot of long-term obstruction, but never seen something calcify like that.
Got it. So can you scroll down to the spleen? Is Mr. Spleen calcified to a la Histo?
It is.
A couple. Okay.
Yeah. Enough. Not. And of course, the whole left lung isn't looking very good because there's no real flow there.
Yeah, and you have nice slow flow into those veins too. On that, on the one you showed with contrast,
Yeah, there's basically nothing going there. Which case was this? I don't remember. Oh, this is another thing where I think we've all seen it. I just never seen it this impressive. This is a patient this is a 71-year-old with CF. I've never seen a CF patient this old. And the other thing is I've never seen bronchial collaterals this massive with really anything except congenital heart disease. And look, I mean, you could see some of these guys just going straight into the PA. I mean, not even, not connecting to a distal branch, but literally just draining right into these.
Yeah.
It's really, really impressive. And if you give me a second, I will pull over the angio, which also shows how impressive this is. And 1 second, sorry.
Yeah, and set that image right there, like the cases we've shown, and like the one we included in the paper, just on the smoke. If you have no contrast in the aorta, then that's going to be inflow of unopacified blood and mimic or be mistaken for PE.
Yeah. I mean, I don't know why these look so strange on the way they did the subtraction, but I mean, literally, it's just straight from the bronchioles right into the lung. I mean, it's not even like a delay of filling. And this patient, of course, is presented many, many times with hemoptysis. So it's just a really, I thought when I saw it, I was like, wow, that's really impressive. And then the last case, which is something that one of my younger faculty showed me, and I kind of blew it off, but I was wrong. See if I can get this to load. Maybe not. Well, I'll just show it on static imaging. So this is a guy who developed a aortic root pseudoaneurysm. I think we've all seen that. And what was interesting was that he developed, so you can see here, and it's really hard with the atrial wall because it's such a thin wall, and there was just homogeneous contrast throughout. But basically this pseudoaneurysm eroded into the left atrium. And so there was a direct aorto left atrial fistula, and the patient rapidly decompensated and died from basically high output heart failure. So you can see here kind of going straight in. And yeah, in retrospect, it's going to be there, but I think you can kind of see a defect in the wall there. So
is that the cause of this pseudoaneurysm, please?
what was the cause? I don't
Pseudoaneurysm.
remember what the cause of the pseudoaneurysm was.
Mm-hmm.
Oh no, he had a cath. That's what it was. This was traumatic. So he had a cath, and as they were poking around trying to find the coronaries, he coded on the table, I think. I think that story is correct. And so, and then he rapidly decompensated on echo. He had a clear pseudoaneurysm from the aorta to the PA. So I don't know if the connection was just a subsequent decompression into the LA, or if the trauma was literally poking through, got the hole, then poked through and got into the LA. I doubt that, but it was. If one of my other faculty know the case a little better, may confirm that, but I think it was, if I remember correctly, a cath-related process.
Got it.
And then this is a case I showed last week, but I just want to, I was thinking about it for a while, and this was a case where this patient had d-transposition and severe pulmonic stenosis and unilateral flow, or almost unilateral flow. It was like 90% right, 10% left. And there was no compression of the left PA. And then I was thinking about it more, and if I don't have it up, and I don't want to waste too much time on it, but you remember when the PA is anterior, the path of least resistance with a PS case is going to be into the left pulmonary artery and not the right. When you look at the angulation between the PA and a D-trans, that angulation is almost reversed. Even though there is somewhat still an angulation from going into the right, there's actually a much steeper angulation going into the left versus the right. So I think, and then so when they relieved this PS and actually did a RVOT kind of reconstruction subsequently and connected the RVOT here into the PA, that flow actually became essentially symmetric bilaterally. So I think, it's just based on the anatomy, this patient had dramatic preferential flow into the right because the PA is not anteriorly placed, and it's not the straight shot into the left PA, but actually more of a straight shot into the right. So I thought that was really kind of interesting, and a follow-up on that case I showed last week. But okay, I'll stop there.
Awesome, thanks. Does anyone else have cases? Well, it might be me then.
I mean, I have some more I can do if you have
some more while I'm showing some.
Yeah.
And then we can go back
Sure.
to. I mean, fortunately, I've got a whole queue of stuff from weeks past that I can go through. Yeah. So start with this one. This is an unfortunate case, but this is a young woman, and this was last month, I believe, and start on lung windows, and you'll see she's got a couple of nodules, and you may have already noticed the major abnormality that I scrolled past, but this was a PE study. A couple of nodules, and these are metastases, but if you notice in her right ventricle and her right atrium, there is this huge filling defect, and this is not inflow of unopacified blood from the inferior vena cava. And as you follow down on this, you can see, well, you can't really see much of it at that point. She did get an abdomen and pelvis CT at the same time, and you can see this is all tumor thrombus, or it's a combination of tumor and bland thrombus, and I'll show you some of the preceding studies. But this actually goes all the way down into her left hemipelvis, and she has a large primary, some sort of large, it was some sort of hemangioendothelial tumor or endothelial sarcoma, or epithelioid sarcoma. But anyway, it invaded the bone and invaded the iliac veins. And this was over the course of like a month that it had progressed this much. She had had a prior study where this was the extent superiorly of this tumor a couple of months before that study I just showed you. And you can see, at least here, it's clearly expansile and enhancing. And that's why I think it's hard to say if this most proximal extent is bland or tumor thrombus. But regardless, the disease was progressing elsewhere, and this was the PET from before. You can see how it started to invade into the iliac veins, into the IVC at that point. So they're trying some new chemo at this point, but it's sad. She's a young patient, and I think I've seen a couple of other cases of frank right ventricular invasion from contiguous spread, from renal cell carcinoma, and one time from a uterine fibroid. But this was one of the more impressive cases I've seen.
What was the primary site? So somewhere in the pelvis? Was
that left pelvis? Yeah.
Just pelvis, not an organ.
No, it was. Oh well, no, it was. I think like in the gluteal muscles or something in here. So it was not a primary intravascular tumor. It just happened to start invading. At least that's what they thought.
So I've seen this with kidney cancers and with adrenal and with liver. So I've seen liver stuff grow into the cava and right atrium.
Yeah, there was a case when I was a resident. I just have a couple of still shots of it. There was almost into the pulmonary artery, but it was contiguous all the way down to the uterus, and it turned out to be a benign leiomyoma that extended all the way up. But yeah, certainly, these occasionally creep up, and this one is not going to be cured with just excision. All right, now I have to remember. Yeah, this is so we had two kind of similar cases that came in, and this is a lady who came in with, she had 4 or 5 months of B symptoms and weight loss. And by the time they did this study, she, as you can tell, had some fairly significant cardiac decompensation, pleural effusions. She's got a pulmonary artery catheter. And on her radiograph, you just kind of lose normal anatomy here of the aorta and the pulmonary artery, and heart looks a little bit big. I won't belabor the radiograph too much because it doesn't show you the full extent of what's going on here. Before she had been admitted, her physician had actually noticed a new murmur and placed an order for an outside echo, but that never got done before this. And by this time, when she came in, you can see on this dissection protocol CT that was done, her aortic valve is really thick, and there are several things that shouldn't be there. These are all vegetations. And I think you can actually see a little hole in the anterior mitral valve leaflet right here as well. And so she had endocarditis of both the mitral and the aortic valves. She also has a little abscess or pseudoaneurysm at the root of the aorta, with along the mitral aortic intervalvular fibrosa. But that's not the full extent of it. And as you can see up here, that she had this curious little thing directed to the pulmonary artery. I think this calcium right here is probably a little bit of the ligamentum arteriosum, and the direction of this fits with that. And so I've got one question I'll throw out there in a moment, but she had all of this stuff in the pulmonary artery as well. So they took her to surgery, and they replaced both her mitral and aortic valves. They replaced her aortic root, and they did find that she had essentially a patent ductus, or what they just said was a fistula, but I think it's probably just a patent ductus that had, and then all of this thrombus in her pulmonary artery. She had also had a brain MR and had several embolic strokes from this, but she's not a drug user, had no other risk factors for endocarditis, and she grew strep mitis in several, or strep mitis, I'm not sure how you pronounce it, in several different cultures, and that was the bug that caused this. But it's just curious that she would have this, and I've seen a thrombosed ductus arteriosus before, but I don't know if this could be the original site and then her valves got infected, or I don't know. Do you guys have any thoughts?
So there was a case it was shown to radiology residents when I was a fellow at UCSF back in the late 70s. It was shown by this very aggressive chest radiologist named Greenspan. And it was a case of endocarditis of the ligamentum arteriosum, of a very mildly patent, PDA. And they emphasized that the presence of calcium, if there's visible calcification of the ligamentum arteriosum on plain radiographs, then in a patient with mysterious symptoms like endocarditis symptoms, you should consider that that was an infected site. So there was a visible calcification on plain radiographs, and that person had endocarditis at that site. So what you're proposing is not preposterous. I would think that if and I just wonder if this is not just thrombus, but is actually vegetation that you're seeing growing into that.
Yeah, whether it's bland or infected, I don't know. And when I looked at the op note, they didn't comment. They just said they resected a bunch of thrombus from the pulmonary artery, and this thrombosed, what they said was a fistula. But
were there PEs from this? Were there downstream things in the lung? Looks like it.
Yeah, I think this is like a subsegmental branch right there. But yeah, so a lot going on here.
Not enough endocarditis in this site, so I think you're onto something.
Well, then let me show you this one. And if anyone else has any comments, please chime in. So this one just came in this week, and this is a patient who's, as you can see, is 45 and is an intravenous drug user who's had a few weeks of worsening symptoms related to infection and related to worsening cardiac function. And he has, as you can see, multiple bilateral, fairly discrete peripheral nodular opacities. And in this case, notice how the trachea, and I can window this a little bit more, trachea is way bowed to the right. There's too much stuff here adjacent to the aortic arch, and we, again, kind of lost our normal arch anatomy. And this was one that was an outside study that was just submitted for interpretation by us. And when I opened this up, I'm not sure if I let a few expletives slip out of my mouth when I was looking at this or not, but this certainly got a reaction. And at first when I saw this was like the first image I saw and didn't know any of the history. I almost wondered if this was trauma, because this arch is just totally chewed up here, as you can see. And notice too that in this case, there's the same thing projecting down to the left pulmonary artery. And there's a fleck of calcium here in the ligamentum. But again, that on its own we see calcium in the ligamentum on nearly everybody once they become adults. This patient also had, you can see, septic emboli in the lungs, and no surprise, splenic and renal infarcts. I couldn't find any actual endocarditis in his case, but this looks like it was the epicenter of this. And he was growing MRSA from all of his cultures. Now, the other interesting thing about this case was that I noticed that made me a little nervous was all of this gas that the esophagus is over here, somewhere in here, and then all of these extra bubbles of gas even to the left of this. And he wasn't having hemoptysis, and there's no fistula that I can see from the aorta to the lungs, or from the lungs to the aorta. And even up here, I think this is the better site, and you can see all of this gas. So they did a swallow study, and I'll just show one series, but he did, in fact, you can see that this contrast is just spilling out towards the aorta. And he wasn't having any blood from his GI tract that we know of at this point. But the CT surgeons looked at him and tossed around ideas of whether you stent both of these. They deemed him inoperative from an open standpoint, and he is actually, sadly, was sent to hospice. But this is MRSA, mycotic aneurysm of the aorta, and presumably, again, also either just direct extension of infection into the pulmonary artery, or whether or not he also had could have had a PDA, or if it just extended along the ligamentum.
So there wasn't any valvular heart disease in this person?
No. Yeah, this was the epicenter of it. So that's why, David, I wonder if it started here. I mean, it must have, obviously.
Could it have started in the esophagus? Could the esophageal leak be the primary site, and then
IV drug user in MRSA doesn't seem like something that would start in the esophagus.
Yeah. But Zowie.
Yeah. All right, here's one. So you guys, I don't know if people are seeing more axillary intra-aortic balloon pumps. I think at some institutions, intra-aortic balloon pumps have fallen more out of favor. This is a good example of one that a finding we've seen a few times now, and I'm becoming more cognizant of. This is not an axillary intra-aortic balloon pump at this point. This is femoral. We don't see any telltale signs of insertion here. And this marker is ostensibly a little bit lower than it should be. But I just show you this as reference, because then a couple days later, now we see the tip has a slightly different orientation. And I can zoom in a little bit here, but notice this is in the interim, he's got surgical or skin staples, and he has the introducer here in the left axillary artery and / subclavian artery. So in this case, this orientation doesn't really bother me that much, because it's probably just directed into the descending aorta like that. But one of my colleagues astutely noticed this was the next day, and notice all of a sudden that you see two markers of the intra-aortic balloon pump, and they're probably 7 centimeters apart. And the shortest ones I know of are 23 or 24 centimeters. And we've now seen this probably 3 or 4 times. And there's really only one explanation, which is that this is looped in the ascending aorta and extends all the way down to the aortic valve and then doubles back into here. Now, I showed one a few weeks ago with a CT. This one actually came in since then. We don't have a CT, but we called the floor. And under fluoro, they confirmed that it was looped on itself and since repositioned it. So I don't know, there's name for a sign or anything here, but if you ever see the markers being this close to each other, then it has to be looped here in the ascending aorta. And this really only happens with the axillary approach, just because you can get ascending placement and arch placement from the femorals, but I think it's something with this thing moving and migrating into the ascending aorta and then kind of flopping back on itself here. And then they were able to, yeah.
Can you show us the previous radiograph? I was looking for that other marker on the previous one.
Yeah, and I zoomed in. It's definitely not there. And this was like right after placement, and then the abnormal one is a day later, and so it's migrated since then. So, and I don't think it's just obscured by motion. But then they repositioned it, and now, David, this looks more like that first one I showed you, and they conveniently shot the entire abdomen, and now we can see if you draw a line, it's going to be somewhere in the 24, 25 centimeter range.
Perfect.
So yeah, but this finding now, we've seen 4 or 5 cases very similar to this now. So, especially with these axillary approach ones, be cognizant of that. Has anyone else seen those? There was actually a case that was written up in Radiology Cardiothoracic Imaging a year ago of a similar finding.
I've not seen it.
Almost all of our balloon pumps now are axillary, so it's a complete pain in the butt.
And they're also well designed, so where they're so visible on radiographs, clearly designed by a thoracic radiologist. Seth, do you have more? I'll keep going.
I do. I downloaded a few more.
Okay. Let me show.
Hold on 1 second. Let me close.
I'll just show a couple more while you're still going here. This is a great one just because I have this CTs that are a day apart from each other. So this is a patient who has a chronic dissection. The ascending aorta has been repaired, as you can see here, and they came in. They were in heart failure or something. I don't remember. That's not really the symptom itself isn't the most important thing, other than pay attention to the right middle lobe pulmonary arteries here. They look fine. And you'll see that this is their admitting chest radiograph. The next chest radiograph, they now have a pulmonary artery catheter. To me, this looks like it's still within the interlobar pulmonary artery, perhaps. This would not justify a phone call from me.
Except that the tip is very dense, implying that it's heading toward us or away from us.
And that's an excellent observation, David, and you know where this is going. But this CT was the next day, so 24 hours apart. And now what are we going to see in the right middle lobe pulmonary artery but this? And right there is the culprit. And as you said, so the tip of it is foreshortened, which is what, stop it. And you can see let me make sure, right there and right there. So I think you're exactly right, David. The fact that it was foreshortened tells us that it was out of the interlobar pulmonary artery and into this medial subsegmental branch of the right middle lobe. And as a result, she developed a small pseudoaneurysm. So, we've seen these. I think this is the first time I have CTs that are 1 day apart that actually show that quick of a development, and clearly the pulmonary artery catheter being the culprit. But then she had a follow-up a week later, and it's pretty much unchanged a week later. So nothing was done at this point, and she's asymptomatic. Of course, the risk being hemorrhage, hemoptysis, and hemorrhage from these. Yeah, but David, that's something, I find intra-aortic balloon pumps, I think we all do, to be a little difficult. But would you have prospectively called this?
Well, I would be suspicious that something's going on just because that tip is not where you think it is. It's a lot more. It's a lot more peripheral than you think. And you see this thing when a intravenous catheter goes into the azygos vein, starts heading away from you. It becomes very white because you're looking through 4 inches of catheter that you think is just a ½ inch.
Yeah.
Because of the foreshortening. So that extra density is a clue that things have gone farther than you think.
But at the same time, when they float the swans, they should be floating them with the balloon advanced or inflated. They must have just stuck it in too far before they inflated it to damage that vessel.
Could be.
Yeah. All right, I will show one more, and this is one that I saw the other day that this is the kind of case that really gets my blood boiling a little. This is an outside case, and again, it was submitted for reinterpretation and confirmation of the outside findings, which were in fact not confirmed, but I'm glad we were able to see it. So this is a 39-year-old, and she's a living renal donor, and she's 5 or 6 days post donation of her left kidney, and you can see she's got a little bit of inflammatory stuff. She's got pneumoperitoneum, and she came to an outside hospital with some left-sided crampiness, and they checked a D-dimer and it was mildly elevated, and so they did a PE protocol CT. And please, for everyone on here, I think most of us are experienced, but these were all called subsegmental pulmonary emboli in the left lower lobe. And I'm not even exactly sure which of these, but the report just said multiple subsegmental pulmonary emboli. And I think I've realized, thinking about just like test performance and stuff, when we diagnose PE on a CT, that's the gold standard. And I think we should aim for 100% specificity, because once this patient has this diagnosis, they carry it for the rest of their lives. And, this is not a pulmonary embolism. There's motion here all over the place. And people ask, well, how can you be sure? And it's like, well, I can't, but I know for certain that what is being called right here is not. So I don't know. Do you guys take the same approach? Like, I always try to be as specific.
It drives me nuts, man.
Yeah.
It drives me nuts. Like, it's so crazy the amount of stuff that gets, and there's that one paper that's from overseas, I think Ireland or I can't remember, that said that they had, 30% false positive rates on their PE studies.
Yeah.
And I couldn't believe that. But then I see some of these reads from the outside and I'm like, well, maybe it is 20% because it's crazy.
And it was, so that was an AJR paper. And I believe, yes, it was of somebody that was a fellow at MD Anderson or University of Texas or somewhere. But yeah, they wrote up, it was like 26 or 27% of their outside studies that they re-reviewed. Because we cited that in the smoke paper. But like, I mean, this is not a PE, none of this is. And I think it just drives me freaking nuts. And it's like, you have to be 100% specific on these, even at the, risk of missing some subsegmental ones that frankly that probably don't matter anyway, because this, so at least we were able to correct the record here. But And obviously, the left effusion can easily be explained by her surgery. It's not uncommon to have small unilateral effusions from intra-abdominal stuff. So, it drives me nuts too.
She doesn't have pneumoperitoneum, does she?
Yeah, she does. Yeah, no, that's what I said. She's only a few days post nephrectomy. So,
got it.
Yep. All right. So, Seth, I will share.
Okay.
Let you take over again. And if anybody else has cases that's come on, please let us know.
So I'll show 3 more. Did you send me the share thing?
No, it might help. Let's see. Make presenter.
All right. So I saw this case and I was like, oh, okay, well, let me ask the chest radiograph expert. What would you say that's your PA? This is the lateral. I just called it a hiatal hernia.
Yeah, there's even air in there.
Yeah, there's air in there.
Sometimes it's a big, if it's not a hiatal hernia, which would be, almost 100% of the time, it could be a diverticulum, and it's nobody who's had his stomach transposed into his chest or anything like that.
No, but it is a patient with achalasia and a massive
diverticulum.
Pulsion diverticulum. Here's the CT.
That is cool.
So here's this, it's just massive, achalasia with this they're Pulsion diverticular, right? I mean, I kind of remember that from medical school or something. That's what they're called. But yeah, so it's just air and fluid in just a massive esophageal diverticulum.
Zowie.
Which case was this? I don't remember. Even though I just downloaded it 10 seconds ago. That's bad. I don't even, let me think here. Let me pull over the. Oh, this was, okay. Let me go to here. this is a lung transplant patient, unilateral, and they're just these kind of strange lines. You know, sometimes you say scarring or you don't even know what it is. But I will show you on the chest CT. It looks like almost like there's pneumomediastinum. When you're kind of scrolling through, you think there's going to be, but this was actually just a massive lung herniation post midline here. And I can't remember exactly why this happened, but this is all left lung herniating across. The posterior junction line is basically pushed over. And she is a patient who has constrictive bronchiolitis. So you can see with the dynamic expirations that, especially with that trapped lung, that's not that interesting of a case, but anyways, I digress. Not that interesting of a case.
Oh, that's a way cool case. So don't be modest, Seth. This is humble bragging.
No, I was.
So this is left. This is, let me get this straight here. This is left lung coming way across the midline.
Yeah, and here's the esophagus, right? So the esophagus is actually back here between the lung coming across.
Do we think that there is a posterior junction line, or do you think it's gone? That it actually,
I'm not sure if it's completely gone or if this is it over here. This is that kind of line you saw coming.
That's right.
On the chest radiograph. There's this line you can see
right
here.
Yeah.
Is this line here. And it was just kind of weird how the PA was, or how the mediastinum was in relation to, it's just strange to see the esophagus all the way back here and then a whole bunch of lung between the esophagus and the kind of going between the mediastinum, because that junction line is just gone.
No, why did she have a lung transplant? What was the underlying lung disease?
I think, I can't remember 100%, but I think it was constrictive bronchiolitis.
Okay.
But this is all kind of lung herniating across between the esophagus and aorta and the kind of heart and regular mediastinum.
Huh.
It's one of the things you look at the chest x-ray, you're like, I don't get it. And then you look at the CT and then you're like, oh, okay, that's really odd.
I wonder what things look like before the
surgery. I'll have to pull that.
Because I've never seen anything like this, and I think it might be iatrogenic, you know.
I think it is. 100% think it's iatrogenic. Yeah, I think it's related to the transplant. That they somehow severed that line on, or they had the lung was maybe instead of, it was too big and they didn't properly do volume reduction, or somehow, who knows.
Yeah.
So this is a really weird case. It's not weird, it's interesting. So this patient has no evidence of pulmonary hypertension. She's a sarcoma patient with Mets, and she's had a long-standing indwelling line. She has chronic pain from her Mets. So the study on 12.5 didn't really, showed her Mets, but nothing else. Then she presents a few weeks later, her Mets are still there, and she has, you can see these faint kind of nodules. And then this is about a few days after that. She comes in and these nodules, she was bacteremic on the prior study. She was even more bacteremic on the current study. I think people kind of know, presumably, where we may be going with this. You can see all these central lobular nodules. And so I kind of gave the, I felt bad. I mean, I saw in her history that, the other thing, look at her right heart and her PA. So her right heart, this is not a great picture of it, but we had a PE study that was done before that. Or let me go to the prior study. You can see how much bigger her right heart is in a very short period of time. So she went from having a normal size PA and right heart to a kind of big PA and right heart in a very, very short period of time.
Catheter in place?
There was a catheter in place, which they removed. But the fascinating thing, is they couldn't figure out. So we showed this in our ILD conference. They couldn't figure out because the bacteria that she was septic with was an oral bacteria. It was some actinomyces that you only find in the flora. And so what we're presuming, and we talked to her, and she's kind of, so since they pulled her line and treated her, she's gotten a lot better. But we're presuming, even though it's yet to be shown, that she was, instead of crushing her pills and injecting them, as most people do, she might have been chewing them up and injecting them, and that may explain why she's septic with a basically a relatively benign bacterium you only find in your saliva.
So I was actually meaning to bring this up one of these weeks. I just finished reading the book Empire of Pain. I don't know if anybody's read this, but it's a fascinating book about OxyContin and Purdue Pharma and the Sackler family. But with the OxyContin in particular, that the crushing up or putting the pills in your mouth to dissolve the coating and then crushing them up and injecting them is what patients do, to bypass the whole time release formulation. So I wonder if that has to do with it. But it's a fascinating book, and it's also, there's a related series now on Hulu called Dope Sick, which we've watched, which is also really interesting. But I've learned a lot. They don't directly reference excipient lung, but I've learned a lot from it.
That's interesting.
Dope Sick is the name of the series?
Yeah, it's on Hulu. But the book is it's investigative journalism, but it's really reads more like drama.
Because it was funny because it's not funny. I mean, I felt bad like mentioning it in the dictation in the first study I read. I said, oh, there's kind of new central lobular nodules. It wasn't this case, the case before, and I felt bad because she's like a young girl, she's got metastatic disease, and I'm like, I don't want to call her a drug user, even though all throughout her notes it's like, opioid dependence, and then I saw it again, and this one I'm like, I had to suggest it, and then we talked about an ILD, and sure enough, they're like, yeah, this is given, I suggested, and they're like, oh, that definitely fits with her.
Well, I think what I've done before is I've dictated excipient lung disease, and then I have telephoned the physician to tell them what that implies. So you can put something in the record that reflects what's going on, and then you can deal with the social impact by talking to the physician.
Yeah, no, I said, it could be I mean, I've seen one case of widespread metastatic disease give you tree and bud and pancreatic cancer, but I said it's unlikely. It's too diffuse to be infection. I said, consider IV talcosis, and I use IV. I understand it's completely excipient lung disease. The issue is that every time I use that, I then get a call from somebody saying, what is excipient lung disease? So now I say excipient lung disease, open quotation, IV talcosis, close parentheses.
But the thing is that it's not talc.
I know, I totally know, but I completely know, but everyone knows it's talc. So
yeah,
but that's why I put like,
yeah, or better
yet,
why I put the email address.
No, I'm telling you, I do put, I put excipient lung disease, and I literally put in parentheses IV talcosis after it, so they know what I'm talking about, because that always, it's like whenever you say something like minute meningoenthelial like nodules, and you get a call from a worried clinician wanting to know what the hell you're looking at.
Yeah.
You're like,
yeah. Another one's metastatic pulmonary calcification. I showed it.
Yes.
Like one of the cases I showed a couple years ago, and it was a renal transplant or evaluation, and the NP called me just irate. He's like, you can't say it's metastatic disease. This patient's being evaluated for renal transplant.
All right. Yeah, no, I've learned that the less phone calls I get, the better. So I try to, yeah. It's also like awesome. The reason I'm very, very hesitant to call emphysema on chest x-rays, because, I mean, I call it, but, there are the cases where you get the very irate patient literally sending you emails or trying to get you, telling you that they never smoked, but of course they lived in a household where both parents smoked for 50 years. But anyways, Yeah, that's what I got.
Awesome. Those are great. Anybody else?
Well,
And there was another chat in there too, HBO, the miniseries Crime of the Century related, which I haven't seen, but I'll check that one out too. All right. Thanks, everybody. See you next week.
Have a good week.
Thank
All right,
you.
bye.